Dr. David. And without any delay, can we go on to the questions?
Yeah, thank you so much, Dr. Shifa. Yes, please.
The first question is, what is pediatric snoring and why do you think it needs attention?
So snoring is a noise that's made because there's a trouble or an obstruction to the breathing. So in a child, that's very concerning that they might have trouble breathing, and that might be normal if they have a cold, or it might be normal if they've had a very busy day and they're very tired, but it's not normal for it to be happening all the time. It will be happening if there is a problem with trouble breathing through the nose, trouble breathing through the throat, which of course is why you need an ear, nose and throat doctor to be involved in these children.
Thank you very much. So there are a lot of parents as well as professionals here. When you said that, it's something that says it's trouble breathing, that's why they're snoring. How often, if a child snores, should the parents or the dentist be alert enough to go in for further research on the same or further treatment for the child?
Yeah, absolutely. It's a very good question. So we used to say 4 nights of the week or more was definitely a problem. There's some research that suggests it only needs to be 2 nights of the week. And then parents will say, well, do they need to snore throughout the whole night, or is it part of the night? The important thing is that any sort of snoring is not to be considered normal. And the other important thing is sometimes they won't be snoring. It might just be heavy breathing. It could even be mouth breathing. So they may not necessarily even be snoring as such, but still have breathing problems.
So for the parents here, if you note, and for the dentist, it's just not snoring, but if you can even hear them breathe, that's something that needs attention. The next question is, what is sleep disordered breathing? And how, as a parent or dentist, you identify, or how can you help them?
So sleep disordered breathing actually covers the whole spectrum of breathing problems in children. And if we look at it from the obstruction point of view, the worst end of the spectrum is what we call obstructive sleep apnea. So that's where a child actually stops breathing. They're so blocked that they actually stop breathing completely. And then we have another form, which is called upper airways resistance syndrome. And that is where the child is not stopping breathing, but has a lot of trouble breathing and is really just struggling to get a normal breath. So they're being choked, but not completely obstructed. Then we have the snoring, and then we have the mouth breathing. So a child may be mouth breathing, and that is not normal breathing. It's not helpful to get good sleep, as are all the other issues with those problems. So sleep is probably the most neglected part of healthcare and well-being, and we know just how important sleep is for good health and longevity.
So can you just please enlighten about the importance of sleep in overall growth and well-being of the child?
Sure. Well, it's important for all of us, of course, but one of the most important things that happens at night time, obviously when we're asleep, is that the brain has a lot of activity that it needs to catch up with. So throughout today, like us doing this talk, for example, we'll have a lot of useful information, and that will go into the short-term memory of the brain. And then tonight, when we sleep, the brain in the background will filter through everything that it's picked up through this and everything else that's happened in the day, and it will decide what is important and what isn't. So that's what we call consolidation of memory. And to do that, you need to have a normal background brain activity. When you don't sleep properly, either because you have a disruption to your sleep, a breathing problem during your sleep, or you have an inadequate amount of sleep, then it doesn't have the chance to do that. So I sort of think about it like a computer that has to do a backup of the data each night. If that computer is turned off, it won't happen. If that computer does not have enough time to process all the data, it'll be an incomplete operation. And then the next thing that then flows on is that the sleep has not been good quality or not good quantity or both. Then you're in a situation where the brain is struggling to function during the day. So concentration, behavioural problems, school problems, education problems, all follow on just for the fact that you didn't get a good night's sleep.
Can you just enlighten, now that we've spoken about the concentration and education, how would this affect the growth of children?
Sure. So we can talk about their physical growth. So that's referencing to how big they grow. So their height, for example. So and that in children, that have this sleep disordered breathing, it affects the release of a body hormone called the growth hormone, which is supposed to come through at nighttime in a special sequence with the sleep. And if the sleep's disrupted, then that release is disrupted too. So these children often don't grow very well. They tend to be small, short children. We look at them, and their younger brother or their younger sister will be bigger than they are, even though it should not be the case.
Thank you very much. So going on to the next question, how would you define the role of a dentist in pediatric snoring or sleep disordered breathing?
So I think the dentist is one of the most important people in this whole conversation from a healthcare point of view. And not necessarily just the dentist, but everyone in the dental team, so the hygienists and the therapists as well. Because, first of all, dentists tend to see children on a regular basis, and they tend to spend a lot more time with them at each visit than they would at a doctor's visit. And it's done with everyone else as part of the dental team. And it gives a chance for the dentist to spot problems. So the dentist may notice that this child has heavy breathing, or that their nose seems to be blocked. They may have gum problems, jaw problems, teeth problems. They may have a tongue tie. They may have big tonsils. All these sorts of things are things that a dentist can readily identify and ask simple questions. Is the child mouth breathing or snoring at night, to get some sense of whether this child actually needs to have further assessment.
Okay. So now that you were mentioning about, for those of you listening, Dr. David's book has these sleep questionnaires, which I would be more than happy to share it on the timeline in Insta as well as FB, so you can use it, and it can be like a self-assessment for the parents as well. So I know this was the last question that we had to discuss, but then when you got up the term tongue, I'm really excited to hear about what do you think that tongue actually does in terms of sleep disorder breathing?
Yeah, so it's a good question that we're still trying to find a very good answer for. So we need to know that there is still some uncertainty about this. But we know, for example, in adults, if the tongue is too big, that can cause an obstruction to the breathing. What we are noticing, but still not fully understanding, is that if the child, for example, has a tongue tie, there seems to be some link with regards to how the jaw grows, in particular the upper jaw, in that it tends to be narrow and compromised in its growth. And then there's a question of whether that then has an effect on the breathing, which of course then leads us to the same situation where it's not just the soft tissue problems, but it also can be problems with the bony growth and development, compromising the airway as well.
Sure. Thank you very much. The next question would be, this is something that we repeatedly ask, which came first, the chicken or the egg? What do you think came first? Was it the mouth breathing that led to adenoids and tonsillitis, or is it the adenoiditis and tonsillitis that's leading to mouth breathing? Can you explain with different case scenarios or examples so we can understand better?
For sure. So what we need to understand is when we have the situation where the tonsils, which is the swollen lymph tissue at the back of the throat, or the adenoids, which is the swollen lymph tissue at the back of the nose, that occupies a space. So in the tonsils, it occupies a space in the throat. With the adenoids, it occupies a space behind the nose. So we need to look at both at the same time. We need to look at what defines the space behind the back of the nose. Well, that basically is the bony growth. So if the bony growth is limited for whatever reason, then there's less space. That means the adenoids have a better chance or opportunity to cause a blockage. So from that point of view, it is something that we need to be mindful of with respect to the chicken and the egg. Is maybe a combination of factors. In terms of what causes big adenoids or big tonsils, the research and the science tends to suggest that it's a viral infection as the underlying thing that seems to be, as best as we can tell, the main player in the game. Possibly some bacterial infection as well. And then the other thing is the presence of reflux, heartburn, indigestion can do it. And then the other thing environmentally is if they're in a household where there's exposure to cigarette smoke, that seems to be not helpful as well. So there's a combination of things that can lead to the tissue being a problem. But the interesting thing that we notice is that when we look at children that have jaw and teeth problems, a very high number of them have breathing problems. and we look at children with breathing problems, a very high number of them have jaw problems. So I think we're basically looking at children that have at least two problems going on at the same time, which when they're combined creates the breathing and sleep problem that we're all very familiar with when we start asking the important questions about snoring and mouth breathing.
Thank you. So now that you've already answered this, but I want you to help us understand better that what are the various causes of mouth breathing that we as dentists and as the parents who are listening also should be able to understand.
Yeah, that's a really good question. So in 80 to 90%, so that's 80 to 90, 80 to 90% of cases, there is some form of physical obstruction to the air flowing through the nose. In the majority of cases, this relates to the adenoids, which is actually, as I said, behind the nose. So the air needs to go through the nose into the space behind the nose, and if the adenoids are big, that compromises that flow. Or it's a problem within the nose. So the nose is separated into two sides, a left and a right-hand side, and that is separated by a structure that we call the nasal septum. And when it is crooked, we call it a deviated septum. So a deviated septum can impair airflow. And then the other structure within the nose is a thing called the turbinate. And the turbinate is a structure that sits on the side wall of the nose. And there's various turbinates. We focus on the ones that sit at the bottom that we call the inferior turbinates. Okay. And they can be swollen from allergy in particular, environmental things again, such as cigarette smoke, or they can just be abnormally big. So they would be the big factors. But then the other thing again is the limited jaw growth means that the nasal space can be less and the space behind the nose can be less. So it's actually also skeletal problems can contribute as well. So it's important to realize that we don't like using the term mouth breathing habit or habit of mouth breathing, because when it's an obstruction, it's actually not a habit. It's a survival mechanism.
Okay. Makes a lot of sense. So for those of the parents who are here or the dentists who are here, if you do not go behind and assess why the mouth breathing is and just put on to the children with some over-the-counter available strips, I'm sure you're aware of those strips, right, doctor? We have
Yes.
had patients try that. So do you want to enlighten the group about, why is it's not okay to start using those over-the-counter strips, and these children will really need an assessment before these are started?
Yeah, I think people need to change the way they look at mouth breathing. Mouth breathing is a symptom, not a diagnosis. So if someone breaks their leg, they have a broken leg, we don't say, go for a run. We know that physical activity and body weight, and so forth is good for developing bone strength. But if you have a broken leg, you don't go for a run. That needs to heal. You need to fix that. It's the same with mouth breathing. If someone is mouth breathing and they have obstruction, that's the cause of that mouth breathing, you don't force them to nose breathe, because it's not going to be successful. You're actually going to cause problems. You can cause heart problems. You can cause damage to the outside of the nose. It can weaken the nose and make it collapse in. And you're actually not addressing the problem. You're trying to address mouth breathing, but you're actually not addressing the cause. So I think addressing the cause of any symptom is very important, regardless of what we might be talking about.
Thank you very much. So mouth breathing in infants. So how would you address this? Because I've had certain theory that, infants are natural nose breathers, and having a mouth open doesn't mean they're mouth breathing. Or how is the mouth breathing in infants, and how early should we intervene with the same?
Yeah. So I guess we've got mouth breathing and then we've got open mouth posture, which are not necessarily the same thing, although obviously there's some relationship there. So the first thing is, you're absolutely right. The child, the infant, is basically there to nose breathe so that they can breastfeed. If they're going to breastfeed, they're going to have to be able to breathe through their nose. They don't want to be having to come up and struggle for breath and feeding at the same time. So breathing through the nose is something that's essential for the baby. And anyone that's ever seen a baby with a blocked nose can see that they actually struggle to mouth breathe just because of their anatomical configuration at that early development stage. It is actually a very difficult thing for them to do properly. So we have certain medical conditions that cause nasal obstruction that actually puts a child into surgery, in the first, few days and sometimes hours of their life. to open up their airway. So certainly any child that is demonstrating any form of any infant that's demonstrating open mouth posture, particularly open mouth breathing, most medical doctors would be very worried about that, and would definitely be getting a pediatric or even a neonatal ENT doctor involved in the assessment and management of such children. Some children are fine to start with, though, and it's not something that necessarily starts straight away, so it could be a couple of months into their age. And it doesn't really matter what age it is. If they start to mouth breathe, then there is something that's unusual that needs to be assessed and managed again, initially with the help of the ENT.
Yeah, so having answered that, but children who mouth breathe, infants who mouth breathe, does have an issue with breastfeeding, right?
Exactly.
Okay.
Because it's the same with any child. Any child that has a blocked nose, if they're sitting at the table having their meal, and they have to eat and chew and swallow, and they have to mouth breathe at the same time, they're the ones that are very slow eaters. They tend to
Yeah.
go for softer foods because they have trouble breathing and swallowing and chewing all at the same time. Their mothers will be saying, close your mouth, but they have to breathe.
Exactly. So now, just a little bit of addition to that. When we have children with cavities, most of the dentists who are watching here, they just directly go ahead and do the drill and fill. But what we don't assess is there a habit, or is there a survival mechanism, as you say? Are they breathing through the mouth? And that is indirectly affecting their ability to chew and swallow. And is that contributing to the cavities is something that we don't have a protocol as a dentist to look into. So can you enlighten us about it?
Yeah, absolutely.
With
I can,
your experience.
because the science is actually published. So there's some really good publications out there where they've looked at the rate of what we call early dental caries. So the development of, as you say, holes in the teeth in children. And they've looked at that in third world type situations, so children that don't have access to fluoride or dental care or toothpaste and those sorts of things. So they've looked at the rate in that sort of environment, and then they've looked at it in the environment of first world with mouth breathing. And the mouth breathing children in the first world have worse rates of early dental caries than children in the third world. So the mouth breathing is actually quite a significant problem.
Yeah. So to the audience here, to the mothers and the dentists and the pediatric dentists that are listening, we might have to have a protocol in place when we have children come into the practice for dental caries or cavities to see how their breathing is. And this really needs a teamwork.